Welcome, everyone. My name is Kate Brocker, Director of the Wellness Institute at the National Epilepsy Foundation. We are so thankful to Dr. Manderscheid and the National Association of County Behavioral Health and Development Disability Directors for hosting this educational webinar today, and are so pleased that you have joined us this afternoon. Today's webinar will focus on medical therapy in epilepsy. The webinar format for today allows for you to ask questions by typing questions into the panel on the right-hand side of your GoToWebinar screen. We will address these questions at the end of today's webinar, but encourage you to type your questions in at any time during the webinar. Please try to keep your questions general in nature, as we cannot provide individual medical advice. At this time, I'd like to introduce you to our speakers for today. Dr. Barry Goodell is a professor of pharmacy and neurology at the University of Wisconsin-Madison School of Pharmacy and Department of Neurology. He received his Bachelor of Science from the University of Utah and his Doctor of Pharmacy from the University of Washington in Seattle. He has also completed his residency as well as a research fellowship in clinical pharmacokinetics at the University of Washington. Dr. Goodell's research interests are in the pharmacotherapy of epilepsy. He has numerous research, clinical publications, and book chapters related to anti-epileptic drug pharmacokinetics and pharmacodynamics, and drug interactions in adults with epilepsy. Dr. Goodell has served on the editorial boards for several journals, including Epilepsia, Epilepsy Research, Epilepsy and Behavior, Epilepsy Currents, and Annals of the Pharmacotherapy. He's also a member of the Epilepsy Foundation's editorial board and has served on the professional advisory board as well. Also with us today is my colleague, Dr. Elaine Karakopoulos, who's the Director of Health Communications and Engagement at the National Epilepsy Foundation. Dr. Karakopoulos is a graduate of McMaster University Medical School in Hamilton, Ontario, Canada. She began her postgraduate medical training as a resident in neurosurgery at the University of Toronto, combining her clinical training with research in functional brain imaging. She completed a research fellowship in functional brain imaging and transcranial magnetic brain stimulation at Harvard University, studying cross-modal plasticity in the adult human brain. She subsequently completed her neurology residency and epilepsy and clinical neurophysiology fellowship at the Beth Israel Deaconess Medical Center in Boston. She remained in Boston, serving as the Harvard medical faculty physician, combining her clinical neurology practice with research to improve health outcomes for people living with epilepsy. Dr. Karakopoulos transitioned to the nonprofit sector in 2016 and joined the National Epilepsy Foundation team in 2018. Thank you both for providing today's learning. And at this time, I will turn things over to my colleague, Dr. Karakopoulos.
Thank you, Kate. And thank you to everyone who's joined us this afternoon. It's wonderful to be here with you today. I'd like to take a moment just to share with everyone the mission of the Epilepsy Foundation. The Epilepsy Foundation aims to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. Today's webinar is made possible through a cooperative grant from the Centers for Disease Control and Prevention. Now, the topic of medical therapy in epilepsy has entire week-long conferences dedicated to it. And what we're going to aim to do today is to provide you with a robust overview targeting this set of objectives, which include looking at the epidemiology, which links psychiatric disease and epilepsy together, the pharmacologic treatment of epilepsy, reviewing anti-seizure medications, side effects, and common drug-drug interactions. We will then talk about adherence in epilepsy and examine risks that accompany a diagnosis of epilepsy and why adherence is so important for people living with epilepsy. We will also provide you with a look at Seizure First Aid and an introduction to rescue medications in epilepsy. We're going to start today's webinar off with a brief review of seizures in epilepsy for those of you who are joining the series for the first time. The human brain is a complex and dynamic structure, and it contains about 100 billion neurons that communicate with one another by sending and receiving electrical impulses and neurochemical signals. Now, normally the electrical activity in the brain is carefully balanced. So a single neuron or A small group of neurons will send a signal to accomplish a task and then stop firing. A seizure occurs when abnormal and excessive electrical activity temporarily interrupts that normal brain function. The image on the right is of a snapshot of an EEG, and what you can see when you follow the squiggly lines reflective of brain activity is that about a quarter of the way into the EEG, something changes. The electrical activity becomes both abnormal and excessive, indicative of a seizure. Electrical disruptions like this can cause a change in a person's movement, sensation, speech, behavior, and awareness. And seizures can have many different outward signs, and the way it appears depends on the type of seizure a person is experiencing and the area of brain involved. So what does it mean for someone to have a diagnosis of epilepsy? The diagnosis of epilepsy indicates that a person is at increased risk for having recurrent or more seizures. It does not indicate a cause or a prognosis. And epilepsy can be described as a spectrum disorder. It's multifactorial, multifaceted, and it really varies in severity from individual to individual. It's also important to remember there are many different types of epilepsy. Now, epilepsy is sometimes referred to as a seizure disorder, and that sometimes happens out in the general public or even by medical providers. Just remember the two terms mean the same thing. Someone with a seizure disorder has epilepsy. More formally, the diagnosis of epilepsy is made when someone has two unprovoked seizures occurring greater than 24 hours apart, or if a person has one seizure with a high chance of having another. The definition of epilepsy also includes that if a person has been diagnosed with a syndrome that includes seizures, even if they only have had one seizure, a person may still be diagnosed formally with epilepsy. Now, anyone can be affected by epilepsy, as it affects all ages, all races, and all socioeconomic groups. 1 in 26 people will be diagnosed with epilepsy during their lifetime, and there are about 3.4 million Americans that live with active epilepsy. Now, between 25 and 50% of people who live with epilepsy will also be diagnosed with a psychiatric comorbidity. This presents both a complex and a very common problem. It's well known that there's a bidirectional relationship between epilepsy and mental health. And if we look at the case of epilepsy and depression, studies have shown this bidirectionality, with patients who have epilepsy having a 5 to 20-fold higher risk of developing depression, and patients who have depression having a 2 to 5-fold higher risk of developing epilepsy. Population-based studies have looked at the increased prevalence of patients with a psychiatric history that precedes the onset of epilepsy and compared them to a control population. And there's good evidence for this to be the case in depression. Studies have also looked at the prevalence of other psychiatric disorders in people with epilepsy. Depression, anxiety, psychosis, and ADHD are reported in this chart. And what these studies tell us is that for each listed psychiatric condition, that the prevalence is elevated in people living with epilepsy as compared to the general population. Today's webinar is going to look at the treatment of epilepsy. Why is it important that a psychologist, a social worker, a nurse, or a psychiatrist have some understanding of medical therapy in epilepsy? This scientific paper is a good example of the questions that are still being studied, so we can have a better understanding of how the comorbid diseases influence one another and affect people living with the disorders. this paper asks, is depression associated with an increased risk of treatment-resistant epilepsy? Questions like, is depression associated with an increased risk of treatment-resistant epilepsy is tremendously important. If we look at anti-seizure medication, considered the first line of medical therapy for people with epilepsy, what has been established is that for people treated with these medications, roughly 2 out of 3 people will be able to gain seizure control, and their epilepsy can be regarded as uncomplicated. But for 1 out of 3 patients, that's not the case. Medications do not control seizures in 1 out of 3 people, and for this group, their epilepsy is disabling. They experience frequent seizures, disrupting daily life, medication side effects, and there is often a long-term impact, which is evident for people with uncontrolled seizures. So yes, it is important for us to look at the impact of depression and other psychiatric disease on the treatment and outcomes in epilepsy and vice versa. There are many questions still to be answered about the intersection of epilepsy and mental health. But right now, I'm going to turn things over to my colleague, Dr. Goodall, who will walk you through the key things to know when it comes to medical therapy and epilepsy.
What I really want to talk about is a big 30,000-foot view of what are some of the issues that we have with our different anti-seizure medications. And by the way, I will probably go back and forth in terminology between anti-epileptic drug and the new preferred term, anti-seizure medication. So we talk about what our therapeutic goal, what are we trying to do? The mantra is very simple: no seizures, no side effects. Okay, that may not always be possible. While that's the ultimate goal, I think our true therapeutic goal is what can we do to maximize efficacy, minimizing seizures, and also minimizing the appearance of adverse drug effects. And also what we try to do is looking at the different qualities of these drugs, which I'll talk about. We're going to try to mix and match a little bit about how we pick certain drugs for certain patients. So let's go to the next slide. That one of the other things I think is very important, and one of the things I try to teach students is, again, a simple mantra: the brain and the mind are in fact the same organ. And I think sometimes we silo things out too much. But what we've really grown to understand over, say, the last 20 years is that there is an interconnection between differing mood disorders. You already heard Elaine talk earlier about this overlap of psychiatric conditions. Well, some of these actually we now know can influence the severity of epilepsy, and sometimes the epilepsy can influence the severity of different psychiatric disease. And another way to look at this is, and we'll go to the next slide, is that seizures may be just one phenotypic expression of what epilepsy is. So take a more holistic view of what epilepsy is, not just that seizure. Again, with this slide, it's just sort of elaborating a bit on that first brain slide, is that we do know that, these other neurologic pathways in the brain, things that innervate our frontal cortex, our ability to have executive function and thought and impulse control, areas of the brain that affect mood. And we know, again, as we've already talked about, mood and epilepsy, mood disorders and epilepsy sometimes go hand in hand. It's not a coincidence. We now know that through dopamine pathways and serotonergic and others, that there is a logical reason and an explanation for this. And in fact, some of our anti-seizure medications may in fact make some of these conditions better. Next slide, please. So back to 30,000-foot view. The common property of our anti-seizure medications is we can suppress and hopefully stop seizures. It'd be nice if they were all that simple and straightforward, but we do know that many of these drugs have differing pharmacokinetic properties, meaning how our guts and our livers and our kidneys process and handle them. We know that there are differing side effects and toxicities as individual drugs and as a class, and also very, very importantly, many of these drugs are associated with multiple drug interactions. Okay, so again, next slide, please. What our ultimate goal is knowing that general pharmacology, and I'll go in a little bit deeper in here, how do we tailor this? And how do we try to mix and match and strike some balance? Next slide. Hopefully this is a graphic showing the introduction of new drugs. Yes, I hope.
Yes.
So we have made, in some respects, we've made a lot of progress. In other respects, we've not made very much. And what do I mean by that? If we go back in time, back to the 19th century and early 20th century, we did have drugs that work. They did suppress seizures. Unfortunately, they were also associated with a profound cognitive impairment and other types of metabolic effects. And then you see there was sort of this glorious period in the 60s and 70s and 80s where we had a number of new drugs that were introduced. Many of these proved to have a little bit better efficacy in terms of seizures than the older drugs. But what we also found began a recognition of is that all these drugs, a lot of them had other baggage, meaning mainly side effects and drug interactions. Well, then as we entered the decade of the brain in the 90s and now continuing on into the new millennium, the new century, that we have a number of newer molecules. Really what the focus of this generation, the so-called third generation, has been to what can we do to minimize side effects and minimize drug interactions. And that's where I mean we've made a lot of progress. Sadly, however, in terms of efficacy, we're stubbornly the same. Let's go to the next slide. And what do I mean by that? When we look at seizure control, there's some data that's, it's, back in the 2001 data, but sadly, it still holds true that if I ask the question, if we have a brand new diagnosed patient with epilepsy, and of all those drugs that I just showed you, if we take the first drug off the shelf, we're going to bat about 50%, meaning that we're going to make, again, our seizure free, right? It's our goal. We're going to make maybe half that will be seizure free. Okay, what if we switch to the second drug? We're going to pick up maybe another 10 to 13%. We'll make them seizure free. After that, things start looking grim. We are now on a different trajectory. And by international definition, once you fail 2 anti-seizure medications given in optimal doses, you are pharmacoresistant, meaning you have a different trajectory, perhaps, and a different expectation for future drug trials. Now, does that mean we stop? No. It means we keep pitching, we keep finding new drugs. But the point that I want to leave you with, and let's go to the next slide, is we need to be aggressive early on. And if knowing uncontrolled seizures and the risk of sudden unexpected death and a lot of these things, we may be able to alter that trajectory. There's some interesting science that says that very, very early aggressive control of seizures, maybe we can influence that long-term effect. But if nothing else, it is vitally important we do whatever we can as soon as we can to get as best control as we can. So the thing I would leave you with, the message I would leave you with, even though these statistics look grim, the grimmer statistic in my estimation is that many patients go years with uncontrolled seizures, maybe only trying 1 or 2 drugs. We need to have every tool in our toolkit available to us, and we need to have a plan for patients to reasonably quickly assess whether these drugs work, and if not, try different drugs or potentially different combinations of those drugs. Okay, let's go to the next slide, please. So it could be a whole other 2 or 3 hours of lectures on the pharmacology of answering the question, how do anti-seizure medications work? The real answer to that is we don't entirely know for many of these drugs. Generally speaking, what they're doing is we're trying to suppress that excessive electrical activity in neurons. And by doing that, one of our main mechanisms, if we think about, from again, a 30,000-foot view, we know that seizures seem to be this synchronous electrical discharge caused by excessive neuroexcitatory activity in the brain. And that's mainly mediated by the chemical glutamate. So many of our anti-seizure medications work to dampen down the release of that glutamate. It also may be that some of our our seizures are due to inefficient braking or inhibition, and that's mediated mainly through GABA, and many of our anti-seizure medications work to enhance or augment GABA. So what does that translate to then in terms of, the bigger picture of picking drugs? Again, if we look at seizure types, and break up the epilepsy seizures into focal seizures, in the old language, that would have been partial onset seizures or generalized seizures. Most of our medicines that we have available to us will work for focal seizures. Most, but not all, will work for generalized seizures. And whether that's a primary generalized epilepsy, which tends to be a genetic epilepsy, or a secondary generalized convulsion, most of our drugs will treat those to one extent or another, but not all. And then there are those patients that, we clearly cannot come up with an epilepsy focus, we can't come up with a mechanism, and we return those broad spectrum drugs. And we have a handful that can treat a variety of things. Okay, so let's go to the next slide. So to summarize, we have a variety of targets available that the different drugs work on. I will tell you again that this is painting a very broad and very simplistic picture of what I just told you. We're learning almost every day that many of these drugs have other mechanisms, or maybe a combination of mechanisms, multiple mechanisms that some of these medicines have that may be contributing. The really interesting thing is we can have two patients that look alike, that look the same, have the same type of seizure, and may respond very differently to these different medicines. So again, we can only take mechanism of action so far. Now, what I don't necessarily have slides on here is, I'm sure everybody has heard about cannabidiol, CBD, or cannabis for epilepsy. I'm certainly happy to answer questions at the end, but the one thing I want to leave you with, we don't really know what CBD is doing to treat seizures, but what I can tell you with pretty much a degree of certainty is whatever this drug is doing, it's working very differently from any of our other anti-seizure medications. Again, maybe we can explore that in discussions. Next slide, please. So why is any of this important? Well, for the first drug, for your decision of what drug to pick, for that patient that presents to you, does mechanism of action important? I would say no. It's important, however, when that first medicine fails. And remember, I told you that about half of those patients or more, it's not going to work. Picking a drug that works with what we think is a different mechanism is a more rational approach. It may not be the only approach, but it is one rational approach to trying to optimize drug therapy. It may also give us a little bit of insight into, let's go to the next slide, please. It may give us a little bit of insight into side effects, okay? And, once we know what the seizure type is, once we've, selected our drug, knowing what that mechanism is and what we can expect, what we also know about our patient, what other kind of medical or psychiatric or psychologic comorbidities they have, the mechanism sometimes can give us some insight as to what a drug may be a beneficial thing to try or may, in fact, be a negative thing. Next slide, please. Hopefully, again, this one's entitled Things to Consider. So what can I tell you then? Let's switch to psychiatric and cognitive and other types of side effects. Sadly, most of our anti-seizure medications can influence cognitive function to one degree or another. I will tell you there's a lot of drugs and drug companies out there that will tell you their drug is absolutely free of cognitive side effects. That may be true in a lot of patients. There are still patients that are going to tell you that they can't think very clearly or things seem foggy, but there are drugs that are clearly worse. I will also tell you, I think it's a general rule of thumb, whenever possible, monotherapy. The more medicines we add on, we may add on 2 drugs that have supposedly minimal cognitive effects, but we add them together and now we have a patient who's complaining to us. Behavior. Some of our anti-seizure drugs may amplify or make worse certain types of behavior like irritability or aggressiveness. An example for that might be the drug levetiracetam, potentially perampanel, Fycompa, that may actually make things worse. There are some anti-seizure medicines that may actually dampen that down and in fact have uses, very valid and good demonstrated uses in psychiatry. So the thing that I'd like you to keep in mind about this, again, I would love to be able to tell you some drugs, and I'll give you some general guidelines here, but know that anything can happen with any drugs. But I do want to move on. Let's go to the next slide and about side effects. I do want to be able to give you some broad strokes of what kind of things to think about. So let's go to the next slide, please. Common side effects of anti-seizure medications. So there's a lot of different things these drugs can cause, and there's a couple of different sort of ways I want you to think about this. First of all, there's allergic reactions. And what do I mean by allergic reactions? The thing that I'm really concerned about are hypersensitivity things that we would see with, say, rash as being probably the most profound example of that, the one that's easy to see. Some of our drugs in some patients can cause significant rash. Some of our older medicines, such as Dilantin or Tegretol or Lamictal, can not only cause rash, they may cross-react. So in other words, a patient who is allergic to Dilantin may be allergic to Lamictal. In some cases, these can cause very significant problems. We have dose-related side effects. Things, again, like this cognitive thinking, problems with balance and dizziness, blurred or double vision, sometimes those things are dose-related. We may not see it at a low dose, but we may up the dose, again, to maximize efficacy, and that's where we begin to see side effects. And then we may have, like, what I like to call them idiosyncratic things we can't necessarily pick up. A lot of problems, for example, birth defects. Some of these, not all drugs, even those that have been associated with birth defects, cause it in every woman who takes it. Things like problems with red blood cell formation, liver problems, those types of things. Weight gain may be idiosyncratic. Some patients are susceptible to them, others aren't. Okay, let's go to the next slide, please. Mood and behavior side effects. And we'll go to the next one. So I think I've touched on a lot of this already. What are some of those mood and behavioral side effects? Here are the common things. Here's the stuff that is the most commonly reported. Probably the ones that are the most, besides the concentration difficulties. And again, what I have a lot of patients tell you is they just sometimes don't feel as sharp. They just can't think as clearly. And that goes from just being a little bit fuzzy to they have memory issues. They can't remember why they got up to walk into a different room or what they were doing. Long-term memory seems to be intact. It's that short-term memory. The other thing is irritability. Some patients, and this can go anywhere from irritability, frankly, all the way up to psychosis and to extreme agitation. Some of our medicines that have been commonly associated with that would be things like levetiracetam or Keppra and perampanel or Fycompa, a newer generation medicine. Very good efficacious drugs, both of them, but they can cause irritability. I'd love to be able to tell you that we have a test that we can predict who that's going to occur in. And again, the science isn't there yet. But the things that are sometimes the most concerning and troubling to me, and the things that we need to screen for constantly, is depression and anxiety. Again, these are common comorbidities in our patients with epilepsy, but we have learned over the years that some of our drugs can make this worse. And let's go to the next slide, talking a little bit about that. What are some of the drugs that we think can cause more depression? And potentially, even in a patient that has never had a history of depression. Some of our drugs, Sabril, which is vigabatrin, which is going to be used more in children, rarely in adults. Gabatril, which is a drug called tiagabine, GABA uptake inhibitor. This is not used very, very often at all anymore, at least by neurologists, but it can cause depression. Zonogram, zonisamide, a commonly used medicine. We have learned over time that this is a drug, especially in a patient with a little bit of history of depression, can make it worse. But the one that's really of concern to me is a drug that's been around for now well over 100 years, and I got to tell you, it works really, really well, but it's phenobarbital. Phenobarbital is a very good drug from an efficacy point of view, but I would use it in extreme caution, be concerned in a patient with a history of depression. And I've already talked about Keppra. How about anxiety? We don't talk about anxiety as much as we should in terms of mood disorder. It's sort of the unexplored area of epilepsy. I've already mentioned a couple drugs. Felbutol is a drug we don't use that much except in very, very, very refractory patients. But again, Keppra and its cousin, Breviac, these are drugs, it's not just the irritability. Patients may not come to you necessarily complaining of irritability, but they just will tell you that they're anxious, or they'll use terms that this audience may be more familiar with than me to describe that, and understand that these drugs can clearly do that. Okay, let's shift gears. Let's go to the next slide, antidepressants and epilepsy. And the next slide. I think I may have, we talked about this earlier, sort of the pleomorphic expressions of depression and epilepsy, okay? And as I tried to mention earlier, that the seizures are just one phenotypic expression of epilepsy. As we've learned more that our patients, there may be all those other transmitter systems I referred to, that we can see a lot of different expressions, and some are of more importance than others, or more prominent, I should say, than others. Depression, major depression. But here's the thing that I think trips a lot of people up. Not all of our patients that come to us are going to be complaining or fit criteria for major depressive disorder. Some of them have something that I like to term interictal dysthymic disorder. A better way to look at this is they just seem bummed out. These are the patients that don't really fit the criteria for major depression, but they're just not that happy. And they're the ones that, they may have some apathy as well that they express. We don't necessarily classify them. Some of our instruments would not diagnose them as having depression. And I think that's sad because a lot of these patients then go untreated. And we never used to think this until some work a few years ago that, bipolar disorder, we also see an overexpression of bipolar disorder in our patients with epilepsy. Okay, next, let's skip the next slide, if we could, the MRI slide, and go to the one that's a correlation between hippocampal volume and depression. If we have that slide up, I want to make just one point. I want to get back to the physiology here, because sadly, sometimes I hear folks say that, well, of course, patients with epilepsy are depressed. Wouldn't you be depressed if you had a chronic disease like this? Well, the answer is yes, but also what's very important for us to understand, again, is the brain and the mind, same organ, the physiology. This was some actually rather groundbreaking work from a few years ago that looked at hippocampal volumes and duration of untreated depression. And we also now have this similar looking data in other epilepsy patients that show that the hippocampus, where we know that a lot of refractory focal seizures originate from mesial-temporal sclerosis, that causes epilepsy. We now know that's also related to depression. So again, these two disorders, there's actually physiology that explains this. Let's go to the next slide. So earlier, Elaine talked about the crossover again, or the comorbidity of depression and epilepsy. Let me take that a couple of layers deeper now, and this is the prevalence of depression in epilepsy. And what you'll notice here is very interesting. If you look at the general population and you look at our percent of patients that are well controlled, by that I mean seizure-free, the incidence of depression appears to be maybe numerically a little bit higher than the general population. But look at those patients with pharmacoresistant epilepsy, meaning they have failed at least 2 anti-seizure medications. The prevalence is far, far higher. Let's go to the next slide. So what do we now know? So what does this tell us? Well, what we think now, again, it used to be we thought it was a one-way street. You had epilepsy and perhaps you developed a psychiatric disorder. What we now know, there's emerging human data, again, from imaging studies, looking at our hippocampus, there's animal stuff, really interesting data that looks like it's a two-way street. that not only does having epilepsy, predispose you to depression, but we now have some very interesting data that having an active depression, may be a risk factor for epilepsy itself. Again, all those pathways that I briefly touched on, these all are interacting with each other. So let's go to the next slide, please. So what does that tell us from a practical therapeutic point of view? What that tells us is we now have interesting information that perhaps using antidepressants, drug not only can maybe treat that depression, but maybe the use of antidepressants may in fact be beneficial in treating epilepsy. So what I mean by that is sometimes we'll have patients that have bad seizures, they're having uncontrolled seizures, and they're depressed. We can't gain control of their seizures until we get some kind of remission for their depression. So sometimes being aggressive and proactive in our antidepressant treatment is important for us to gain control. So again, brain and the mind, same organ. It also makes the argument where psychiatry, psychology need to work together. So let's go to the next slide. So what does that mean for our patients? It means not only drugs are not always the right answer. More and more, in our clinic, we're trying to incorporate CBT, cognitive behavioral therapy, and sometimes combination of both to optimally treat not just that mood disorder, but to treat seizure disorders. Okay, so let's go to the next slide, please. Our overall aims of pharmacotherapy, treat everything, okay? We can't treat them in silo things anymore. We need to look at treatment, get remission of all symptoms of depression and anxiety. We need to not be afraid to use antidepressant medicines in our patients with epilepsy. We may need to adjust the dose, maybe not, with patients on enzyme-inducing drugs, but we need to be aggressive with treatment of both of those. Okay, so I think I'm going to, if we could now, for the sake of time, I'd like to go down to the slide, please, Ryan. I think it's 47, risk of suicidal ideation. So what about suicide? Here's what we know. This is something we've become acutely aware of in the last few years. The risk of, we know that if you look in the general population, what the risk of suicide is, and not only ideation, but actual attempts. People with epilepsy, it's a lot higher. Let's please go to, so let's talk a little bit deeper about that. Can we go to slide number 49, about FDA alert on suicidality? Great. So what do we know? We know a couple things. The FDA went back and looked at this a few years back, and interestingly enough, there was an overall risk from the placebo-controlled trials that have been published for increased risk for suicidality in patients receiving anti-seizure medications as compared to placebo. Now, that created a lot of panic with a lot of people, because if you don't understand that statistic, it says people interpret that there's an 80% risk of suicidality. No, there's an increased risk. And what that really means is, yes, there are more suicidal events, if you will, in patients with these anti-seizure medicines. But again, the numbers are still very low, all right? So a lot of patients early on were very scared of this. They thought, I don't want to take these medicines because of the potential risk for suicide. We need to reassure our patients, no, that there is an increased risk, but there's also the benefit, like we've just been talking about, the incredible benefit of treating the seizures themselves, okay? So we need to be able to reassure patients. What can I tell you about the different anti-epileptic medications, anti-seizure medications? If we go to slide 50, here's what I can tell you. There's no real clear winner or loser here. We don't really have overall any drug that's better or worse. If you look at this slide, I've got a little red circle around lamotrigine. That's not to imply that lamotrigine causes more suicidality. I think the explanation for that is we tend to treat more patients with mood disorders with lamotrigine because it has been shown, it's FDA approved in bipolar disorder, and it's also been shown to have some mood elevating effects in our patients with epilepsy. Okay, so the bottom line here is patients with mood disorders, be that depression, anxiety, irritability, we need to look at the whole picture. We need to look at good control of seizures as being one very good treatment for that. And then, but we do need to think about the different medications and what they possibly can bring to the table here. Okay, very quickly, let's go to slide 53. I want to talk about drug interactions. I will tell you that the pharmacokinetic, there are pharmacokinetic interactions with these different medicines. Some of our drugs are enzyme-inducing medicines, meaning they rev up the activity of these drug metabolizing enzymes. Some are inhibitors, meaning they can slow down the activity of some of these enzymes. Some do both. From a practical point of view, what does that mean? One of the things it means is it can affect sex hormones. Some of these drugs, remember our sex hormones, testosterone and estradiol, are metabolized by these same drug metabolizing enzymes. This may explain why some of our patients have depressed libido and sexual activity. Vitamin D is metabolized by these enzymes, and vitamin D levels we've shown in some of those enzyme-inducing medications can actually be depressed, and this may be a risk factor for developing osteoporosis. Slide 54, please. Next slide. So again, there's a number of our older, the drugs that seem to be the most common culprits, if you will, for this are our older medicines such as Tegretol, phenobarbital, Dilantin, and one we rarely use anymore, primidone. So carbamazepine, phenobarbital, phenytoin, and primidone. Besides those effects on our own endogenous hormones, we have to think about other medicines that this may impact. And those other medicines can be anticoagulants in our young women, or think of oral contraceptive pills. We can decrease the activity. And they may have an impact on antidepressants and antipsychotics. And very importantly, in our cancer patients, these have been shown to potentially reduce the efficacy of anti-neoplastic treatment. Go quickly to the next slide, number 55. Again, just re-emphasizing this. So thinking about our psychotropic medications, both the typical and a lot of the atypical antipsychotics, these enzyme inducers can reduce serum concentrations. I think clearly for showing in terms of schizophrenia, that probably has an impact. Whether it's affecting the antidepressant activity of those drugs is a question we still don't know. We go to slide 56. We do know that some of these drugs like valproic acid may actually do the opposite. And we have evidence that valproic acid, which we may be using for bipolar patients and mood disorders, may actually raise the concentration of some of these drugs. So in summary here, there's a variety of things we need to pay attention to and think about in terms of how we pick these drugs. Pharmacology, mechanism, clearly one thing. Side effect profile, I think we need to be thinking more about the behavioral effects and mood effects than we do. And then finally, drug interactions. We need to always be asking the question, if the other medicines I'm using aren't working or maybe causing problems that I wouldn't anticipate, are my anti-seizure medications interfering?
Thanks, Barry. We're going to spend a bit of time now reviewing medication adherence in epilepsy and risks that are present for a person living with epilepsy. So one of the greatest problems in treating illness is the failure of patients to take medications they are prescribed correctly and in some cases at all. The average percentage of patients who fail to take medications as prescribed was estimated by the World Health Organization to be right around 50%. Now, studies have helped to determine the behaviors or actions of patients after a prescription is provided to them. And what we've learned is that about 1/4 of patients do not take medications at all. So they receive a prescription, but then they don't go out and get it filled. About 28%, or just slightly over 1/4, stop taking their medication before a prescription runs out. And 22%, so almost a quarter, so almost 1 in 4 patients take less than the dose prescribed. Adherence to medication, we know, is a multidimensional phenomena, and it's determined by the interplay of different factors. And they're termed dimensions by the World Health Organization. Now, these sets of factors include social and economic factors, healthcare system related factors, condition related factors, therapy related factors, and patient related factors. If we examine closely and break down these dimensions and appreciate the sentiments that patients share, there are several barriers to adherence to consider. Complexity, so there are too many pills, I can't keep them straight. Cost, memory problems, not understanding why a medication is required. For some people, when they feel well, they stop taking medications, not recognizing the preventative aspect of the medication they are taking that allows them to feel well. And this can sometimes be the case in epilepsy. People think, well, I haven't had a seizure in 6 months. I don't really think I need to keep taking my medication. Another contributing factor in epilepsy is embarrassment and stigma, which can lead people to not taking medications. From a psychiatric disease standpoint, depression in and of itself can contribute to poor adherence. So you can imagine how the combination of comorbid disease might affect adherence. Health literacy is also a key barrier. And as providers, we have an obligation to try to overcome this issue by ensuring the appropriate education and counseling and supports are available around medications. Finally, belief systems, whether individual or cultural, can influence behavior when it comes to adherence. If we take a closer look at non-adherence in neurologic and psychiatric diseases, you can see that both for epilepsy and depression, non-adherence sits at approximately 40%. And studies that looked at medication non-adherence specifically in epilepsy compared to other chronic medical conditions determined that non-adherence was a problem for between about 1/4 and 2/3 of patients. Now, in epilepsy, studies have also demonstrated that non-adherence results in increases in emergency room visits, hospitalizations, and injuries related to motor vehicle accidents. Additionally, compared with adherent behavior, so compared with people who take those medications, if someone doesn't take their medication, if they're non-adherent, that's associated with a 3-fold increase in risk of death and increased per patient emergency room and inpatient hospital costs. Now, why are adherence and removing barriers to adherence so important in epilepsy? Well, because we know that a person living with epilepsy faces increased risks that include seizure emergencies and complications from seizures, accidents and drowning, drug reactions, suicide, and sudden unexpected death in epilepsy, which is referred to as SUDEP. So just for a moment on SUDEP. SUDEP occurs when a person with epilepsy who is in their usual state of health dies unexpectedly and no other obvious cause of death is found. It affects 1 out of 1,000 people with epilepsy each year. And for people with poorly controlled seizures, the risk is even higher. Recent clinical guidelines have shared that for people who have more than 3 generalized tonic-clonic seizures a year, and people who have seizures which occur at night, the risk is further elevated. So it's very important that patients who have been prescribed anti-seizure medications follow their doctor's directions and take their medications regularly and reliably. The risk for breakthrough seizures when medication regimens are not followed are high. If you are caring for a patient with comorbid disease and they share a history of non-adherence, counseling around these risks and immediate referral back to their neurologist is vital. There may be a reason, cost, or side effect that's led them to not taking their medication. And this should be explored and solutions implemented, whether it be a trial of a different medication that needs to happen or an appeal to an insurance company. Non-adherence in epilepsy can result in injury and death and really needs immediate attention. We're going to move on now to review Seizure First Aid and have Dr. Goodell introduce to you another type of medication used in epilepsy called rescue therapy. The three basic principles of Seizure First Aid include staying with the person, keeping the person safe, and in the appropriate circumstances, turning a person on their side. Stay, safe, side are a good simple guideline for thinking about seizure first aid. The other key concept you'll want to take away is related to timing a seizure. And the importance of doing so, with the critical number of 5 minutes as a guide to your response. Let's walk through what you can do in the event of being present when someone is having a seizure. Recognizing that there are many different types of seizures, and you'll need to tailor your response appropriately. However, the common principles we just discussed always apply. If you are present when a person is experiencing a seizure, you want to stay with that person. Remain calm and keep those around you calm. Check for a medical ID and use your watch or your phone to begin timing the seizure. You're going to want to keep the person safe, so move harmful, sharp, or hard objects out of the way. And if they happen to wander during their type of seizure, try to gently guide them away from dangerous situations like traffic or terrain that is rocky or uneven, where they may fall and injure themselves. If the person loses consciousness, you want to gently guide them to the floor or ground. Turn the person onto their side to help clear saliva and keep the airway open. Put something soft like a jacket or a sweatshirt under their head and loosen any tight clothing like ties or scarves that may be around the neck. Never put anything in the person's mouth and don't offer food or medication unless they're completely awake and aware. You never want to restrain a person during a seizure. Holding someone down during a seizure does not stop movements that accompany a seizure. The movements will stop when the seizure ends, and most seizures last between several seconds and a few minutes. After the seizure ends, stay with them until they are fully alert and aware. Offer some reassuring words and let them know in simple terms what has happened and that they are okay and safe. If necessary, offer to call a loved one to help them return back to their home safely. Most seizures are not medical emergencies, but there are instances where 911 should be called. These include if a seizure lasts longer than 5 minutes, if a person has repeated seizures, if there is any difficulty with breathing, if the person is injured during the seizure, or is pregnant, or is in medical distress. If a person does not return to their usual state after a seizure, 911 should be called. For seizures that occur in water, 911 should always be called, as a medical evaluation is always required. If this is someone's very first seizure, they should be transported to the emergency room for an evaluation. You are going to want to share information about how long the seizure lasted and a description of what you noticed during the seizure when emergency personnel arrive to help. Remember, timing the seizure is important, and sharing that information is also important. Timing the seizure is important because guidelines have established that if a convulsive, generalized tonic-clonic seizure with a loss of consciousness is prolonged, lasting more than 5 minutes, it is defined as status epilepticus, a seizure emergency. This also applies if a person has repeat seizures over a prolonged period, not recovering between seizures. 911 should be called in both cases. And with that information in hand, I'm going to turn things back to Dr. Goodell, who will introduce you to another set of medications used in emergency settings, both inside and outside of the hospital.
Lovely. So get back to a little bit of the pharmacology. We talked about, drugs are either working to decrease that excitatory activity or they're working to enhance that inhibitory activity. What do we know about in acute seizures? So someone is having either cluster seizures or acute recurrent seizure, things that also make us really worried that they're going to go on and develop status epilepticus. We want to stop that process really quickly and soon. We have very good evidence going back years that a class of drugs, the benzodiazepines, meaning things like Valium and Ativan and Versed, so diazepam, lorazepam, midazolam, all of these benzodiazepines, we know from years of experience, if we give them quickly, that they can stop a seizure. The problem is most of these drugs are given in the hospital setting, are given IV. That may not be possible or won't be possible in, say, a kid in school or somebody at home or in the workplace. So over the last couple of years, the last few years, we sometimes send patients home with oral tablets of a drug like Valium or Ativan to acutely stop a seizure. But again, that drug has got to get absorbed, and it takes a while. So there's a whole new delivery system, the formulations of these older medicines that are now starting to come to market. You're going to see them over the next couple of years. For a long time, we have a rectal device or administration of Valium, of diazepam. It goes under the name Diastat. Now, it works really well, but as you might imagine, rectal delivery is not practical or convenient or desirable in a number of situations, especially, say, in a school setting or in the workplace. There is now a development for both what's called buccal administration. There's going to be little strips that you actually can either put on the tongue or on the side of the cheek that rapidly dissolve and give this drug very quickly. The first one that'll be coming to market is actually an intranasal version of a drug called midazolam. So it's actually like a nasal spray. You'll squirt this thing in. Anybody can give it. It's very simple to give. And it's been shown to get absorbed very, very, very rapidly and terminate seizures. So we have a whole new, not necessarily new class of medicines, but just new ways of giving it, both in the nose and in the side of the cheek, that I think are really going to be important for us in the acute management of patients.
Thanks so much, Barry. This brings us to the final part of today's webinar. We wanted to be sure to share with you that there are a number of resources you can turn to after today's session to continue learning about epilepsy and medications used to treat epilepsy. Resources for providers and patients and links to these resources can be found on epilepsy.com or by calling our Epilepsy Foundation 24/7 helpline. This presentation and the list of resources you see on this slide will be available for viewing on epilepsy.com. I would like to thank Dr. Manderscheid for supporting and guiding this work in behavioral health and epilepsy, and for giving us the opportunity to be here with all of you today. I'd also like to offer special thanks to Dr. Goodell for sharing his time and his incredible wealth of knowledge and experience with us this afternoon, and for his steadfast support of the Epilepsy Foundation and the epilepsy community at large. Dr. Goodell, thanks so very much. I want to thank each of you for your interest and attention today, and we hope you'll join us in the future as we continue to share with you regular webinar learning sessions that are focused on the intersection of epilepsy and mental and behavioral health. You can find updates for new learning opportunities on the landing page at epilepsy.com and via Twitter, Facebook, and LinkedIn. Thanks so much, everyone.